Good morning. Great introduction, except for the basketball part. I went to Duke, which is a problem, but we'll probably be able to get over it. So I'm going to change gears a little bit today and talk to everyone about some, essentially, compilation of research I did in my training. Me and a group of residents, partly out of, I guess you could say, selfish reasons. You know, when you're a junior resident and an intern, you get a lot of consults, a lot of phone calls from medical doctors in the hospital. Can I start anticoagulation on this patient? Can I start Dvt prophylaxis on this patient? When is it safe to anticoagulate? Something that we hear all the time, and still, even in practice, of course, everybody knows what I'm talking about who's been on the receiving end of a neurosurgery page or a phone call. So me and a bunch of guys got together and we looked at, you know, why is Dvt a problem? Well, it's a common thing. It happens to about 1 to 2% yearly in the general population. But, you know, getting a blood clot in your leg, okay, is that really a big deal? Well, not always, but when they travel to the heart, they can go to the lung, and you can get a symptomatic PE, and sometimes a PE can cause death suddenly. So yeah, that's a problem. Dvt that stays in the lower extremity can cause pain. You can get swelling from it in the limb. And even after it resolves, you can have something called a post-thrombotic syndrome, where you essentially have venous reflux related to that Dvt. And complications can be high, rates as high as 20 to 30% in the literature, depending on where you're looking and what you're reading. So the pathogenesis of Dvt formation, we all heard about Bruchow's triad in medical school, this idea of endothelial injury. When the endothelial cells of blood vessels are injured, they trigger a response that results in some kind of hypercoagulability and local platelet aggregation and formation of a thrombus. And then also some people, of course, for instance, women on birth control pills or people with lupus or some kind of antiphospholipid syndrome have a baseline hypercoagulability, and they're more prone to development of Dvt as compared to the general population. And then there is essentially abnormal blood flow is the third component, and this just means slow blood flow in a way, or stasis. So the blood pools in the legs, you can develop Dvt. This is why they tell people, stretch your legs, get up on an airplane, take a little walk. And a lot of people, a story we've heard before, unfortunate story, people take a long airplane flight and they're found dead in their hotel the next day because they had probably a Dvt form that traveled to their lung. And then there's, in my opinion, probably a fourth, or let's say a 3A category for Virchow, this idea of inflammation, which probably pairs with hypercoagulability to a certain degree. So inflammation in general promotes platelet reactivity. Platelets are the clotting cells. And people can have higher levels of prothrombotics in their tissue. Something called tissue fracture causes hypercoagulability. Fibrinogen platelet activating factor, von Willebrand factor, all these proteins and factors the body makes to form clot when we need a clot to form, when we injure ourselves, can sometimes be ramped up to abnormal levels, and this can result in formation of Dvt, which is why we use ESR-CRP as a marker for Dvt. If it's positive, that means you have a high inflammatory response in your body, so it doesn't necessarily predict Dvt, but if it's negative, you probably don't have one, so it's somewhat of a sensitive test. That's why we use it. What are commonly quoted risk factors for formation of Dvt in the general population? So age is the most commonly reported. Apparently 70 is an important cutoff. You have a greater than 20% higher rate of developing a Dvt compared to young people. And 40 is probably the second tier. It's 40, a little higher, and then 70, it goes way up. And then others that have been mentioned in the literature, of course, are gender, ethnicity, how long you're in the hospital, specifically how long you're in the ICU, your blood type, your pre- and post-operative neurological condition, right? So if you have a neurological deficit and you're hemiparetic, hemiplegic, paraplegic, you don't have as much use of your limbs, and blood can stase, and you can theoretically get a Dvt from that. People on steroids, people who've had chemo, radiation, and of course, people who are already anticoagulated because they've had a clot in the past. So VT in general, DVT or PE, is higher, period, in surgical patients compared to people walking around in the general population who don't need surgery. I mean, that makes sense, right? Because in the post-op period, you probably have a ramped up inflammatory response from all the tissue injury that surgery did to you. Plus, you're on an operating room table, immobilized, potentially for long periods of time. You have limited post-op mobility because you're recovering, you're in your bed more than typical in the hospital, you're not getting up as much. And then, of course, genetic factors always play a role. And if we compare, for instance, ortho patients, so people have probably heard, in the ortho services, these guys are given Coumadin or anticoagulants basically day 0 or day 1 when they're doing hips or joints and total knees and all these things, because they recognize, this patient has a higher risk of a DVT, so they prophylax. All right, they have a protocol for it. So wouldn't it be nice if we did as neurosurgeons? And then if you look at going to surgery for lung cancer, it's about 2% of the people that undergo surgery for lung cancer end up getting a DVT or a PE. But then if you look at people undergoing brain surgery, right, the rates are stable to much higher, depending upon what study you're looking at in the literature. And these people that get DVTs, obviously a certain percentage of them will get a pulmonary embolus, and then some of those people are probably going to pass away from it. So brain surgery is the highest risk patient population of all surgical patients. Then if you look at people with brain tumors, the rates are even higher than patients with other malignancies who don't have brain tumor component. So venous thromboembolus, again, significant increase in mortality in cancer patients. That's been published, that's been proven. You can see this chart here, that it is listed as highest in pancreatic patients, but brain is the second highest. So it's high in patients with brain tumors, okay? And it's high, whether we're calling primary brain tumor, benign or malignant, or a metastatic brain tumor. It seems that patients with brain tumors have higher rates of venous thromboembolus. And one of the physiologic explanations for that is potentially this increased level of circulating tissue factor in the bloodstream that tumor cells express, okay? And actually there is a study that we found when we were doing our research that showed that microparticle levels, which are essentially components excreted by tumor cells that also ramp up tissue factor excretion, are higher in a post-op patient if levels are drawn after surgery for a high-grade glioma. So there is some scientific data to support this idea. So prophylaxis strategies that neurosurgeons use, okay? Surgeons are often scared that we're going to have a post-operative hemorrhagic complication. Nobody wants to put their patients on anticoagulation, even prophylactic doses. Okay, so what do we do then? We recognize this is a problem, we got to do something. We use SCDs, compression stockings. We try to get the patient to ambulate early. Okay, and these things do work. There is some evidence that they work. If you look at percentage of DVT, a prospective cohort, 8.8% developed DVT with compression stockings, 9% developed DVT when they used SCDs, but about twice that developed DVT when no prophylactic strategy was used. And then, of course, there's the chemical or pharmacologic prophylactic medications that are frequent use now in the hospital population. And when is it good for us to put our patients on these medicines to prevent DVT? And this study showed that essentially they work in tandem, so they have an additive effect. If you put your patient on STDs or stockings or both and pharmacologic prophylaxis, you're probably going to further reduce their risk of venous thromboembolism formation. And the problem, of course, this slide shows the same thing I just mentioned. The problem, of course, is that neurosurgeons probably underestimate the risk of development of a DVT, the severity of that development of a clot, and prefer not to use pharmacologic prophylaxis for fear of intracranial hemorrhage. This study was done about 10 years ago and surveyed a bunch of neurosurgeons and essentially found those results. So, like I mentioned earlier, me, a couple of my co-residents, a few years back, we decided to see if we could find the right answer for this. Okay, when should people go on DVT prophylaxis? When should they get their Venous? All right, so we reviewed all of the patients who had brain tumor surgery at our institution over about a 10-year period of time. And the results were published a year or so ago in the Journal of Clinical Neuroscience. So this was a retrospective electronic chart review. We sat down, we found the names of all the people that had had craniotomy for tumor. We combed their charts, created spreadsheets. We looked at a bunch of different factors, the medical comorbidity, the demographics, whether or not they developed a DVT or a PE in the hospital after their surgery, and all the other variables that you could possibly imagine. And something that was unique to our patient population, for whatever reason, we were actually screening patients for DVT at Northwestern for a long time. I'm not exactly sure how that protocol started, but if you were in-house on Monday, you were going to get screened for DVT. Or if you were in-house for more than a certain number of days after surgery, you were going to get screened for a DVT. And ultimately, we found a lot of DVTs, and a couple things happened. One, the vascular techs hated us because it was so much extra work. And two, the hospital started getting dinged because we're finding conditions that people develop in-house, and of course they're not getting reimbursed. So they actually made us stop. Whether or not, is that the right thing, right? It's like burying your head in the sand. We know it's a problem because we've recognized it. But if we ignore it, I guess it's not as much of a problem. So I have no idea how many patients went home with a DVT and died of a PE that could have been saved. But that's essentially the politics of what happened where we were. Anyways, we had about 1,100 patients total over about a 10-year period. And we did a bunch of stats on them. These are the pre-op characteristics. So the tables are a little busy. I'll try to summarize them. At the bottom, mean age about 54, slightly overweight population, mostly Caucasian, lots of heart disease, 5% previous blood clot in their history. A lot of people with cancer and seizure disorder as well. Our mean operative time is about 2.5 hours. Post-op ICU stay was a little under 2 days. Hospital stay approximately 6 days. And we found 13.7% of all people in this group who got Dopplers had a DVT. 3.3% developed PE. So that makes for a total venous thromboembolism rate of 17.1. So not everybody was screened, but a lot of people were screened. So that's 17.1% of the screened patient. 75% patients had surgery for supratentorial brain tumors, and 82.5% had surgery in a supine position, as opposed to a prone, lateral, or sitting position. High-grade glioma in this population was 29.8%. 20.5% with Mets, 20% with meningiomas, and then a few low-grade gliomas. That's pretty typical, right? That breakdown of what we do surgery for in the brain, for brain tumors, primary tumors, and Mets, and meningiomas are the lion's share. Then our results. So risk factors, when you're looking at univariate analysis, for female gender, actually. Age, so older than younger. And then prone and supine positioning were actually higher risk of developing a DVT than lateral or sitting. And then tumor histology. So I want to harp on this finding, this tumor histology. Type of tumor that you had was very predictive in our study of whether or not you developed a venous thromboembolism in-house. And this was reproducible no matter how we ran our stats. Okay, people who were also at risk were patients with pre-existing heart disease, a previous cancer diagnosis, okay, maybe because of that whole cancer and hypercoagulable to begin with, people with seizure disorders, and of course people with previous history of a DVT for the whole, I'm hypercoagulable or what have you. Length of ICU stay, length of total stay, and lesions in the posterior fossa also had some significance in terms of their risk for patients developing with DVT. And then we did different stats, logistic regression, again, gender, ethnicity other than Caucasian, prior history of blood clot, we've seen that one before, ICU stay, we've seen that one before, and tumor histology. are the most significant risk factors after craniotomy. So women are more likely, Caucasians not as likely, and of course if you have a history of a blood clot, you're very, very likely to have another, especially after surgery for brain tumor. And then people that left the ICU day 1 or earlier actually had reduced risk, which makes sense. Dvt screening, this is just another slide that shows what I mentioned earlier, that about 70% of our total 1,100 patients were tested or screened. And this is the percentage screened that were diagnosed. Okay, so we missed about 30% of our patients. And I want to reiterate this point, tumor histology in DVT. So of all the patients, this is their tumor breakdown, this is their histologic breakdown. Okay? And how many of those patients with that particular histology were found to have a DVT on screening Dopplers? Again, these higher grade lesions, metastatic tumors, primary glial neoplasms, higher grade gliomas, they are the most risky patients. Again, tumor histology, strong predictor. Okay? People with METs, 23.8%. People with high-grade gliomas, 21.4%. An angioma, much lower. Benign tumor, 8.2%. Despite the teaching in neurosurgery, people with meningiomas, they're hypercoagulable, they're going to have a blood clot. Well, yeah, but not as much as somebody with a GBM or breast cancer met. Discussion. So I thought our study was unique for, as I mentioned before, we did screening Dopplers, okay? Whether or not, this is still a retrospective chart review. There's some bias, of course, it's not the best designed study, but it added something to the literature that nobody else had done. Again, we screen weekly, even asymptomatic patients. Usually, people only order Dopplers when somebody develops a symptom of DVT, asymmetric blood swelling, something like that. Patients weren't screened before admission, right? So we don't know, did they come into the hospital with the blood clot, or was it the actual surgery that caused the blood clot? We just don't know the answer to that. And of course, there's no great evidence on when, in our study at least, the chart was, there was a lot of error in it, right? We didn't know what day we started DVT prophylaxis, if at all, what kind, because we were looking back almost a decade in some patients. So that limited us being able to at least conjecture about what the answer of safety of anticoagulation might be. And again, the most notable finding was this idea that people with high-grade brain tumors have a higher risk. And this is actually something that another group reported, it's Chaichana. They looked at like 4 times as many people as we did and found that patients with higher grade tumors had a higher risk of DVT formation. So what do we do about timing of prophylaxis, right? So the American Society of Clinical Oncology made some very vague guidelines. They said Lovenox is a preferred choice, but when to start it, they didn't really say. They just said if you have cancer and you're getting major surgery, you should probably be started on Lovenox at some point. Okay, great. So in neurosurgical literature, what do we really know? So actually, despite the fact that most surgeons think Lovenox postoperatively is going to increase your risk of intracranial hemorrhage, we don't know that for certain from the literature. In fact, the only paper we found that showed administering DVT prophylaxis increases your risk of intracranial hemorrhage was when it was administered before they had surgery, which that of course makes sense, right? If you go into surgery anticoagulated, even to a small degree, you're probably going to have a bleeding complication more often than you would if you didn't have that medicine. But when people gave it after surgery, regardless of modality or when it started or how often they gave it, those are all variables also that should be answered. There didn't seem to be much of an increased risk in other publications. Okay, and I'm listed this paper here. So the study done at UCSF. There's Berger and Michael McDermott do a lot of brain tumors, especially Berger does a lot of gliomas. They did a similar study, not many patients, but it was more prospective, whereas it was retrospective, and they focused their study on patients only with meningiomas, but found that if you give Lovenox after surgery, they get fewer blood clots and they don't get more hemorrhages in the brain. Conclusions from my talk. So what I usually do in my practice is early DVT prophylaxis after craniotomy. I mean, most of us get a scan the first day after surgery anyway. If there's no bleeding on there, if it's small, it's just in the cavity, it's just this fibrillar surgery cell you left behind. You know, that's your baseline. The patient has a great neurological exam. It's probably safe to start heparin 5000, Lovenox 40 within a day or two after surgery. There's an antibody that says it's safe. More people seem to recognize it and tend to be doing it more often. And if you're really on the fence about should I do it or not, I would urge you to do it if your patient has a high-grade brain tumor, if they're hypercoagulable, had a PVT before, if they have a post-op or pre-op deficit that keeps them in the ICU, or with limited mobility after surgery, really think hard about starting it, in addition to TEDs and SCDs. Of course, this does nothing to answer the question of when can we fully anticoagulate people, but one step at a time. And then there's also this, should we be screening GBM patients before surgery? Should we be screening patients who have breast mets or lung mets before surgery? That way the hospital, they don't say you can't screen people for Doppler's. Well, if it's a pre-existing condition, then the hospital execs is like, okay, well, at least we're not going to get in trouble. You can save your patient potentially. And this whole idea, well, in super high-risk people, should we put filters in them after for potentially the remainder of their lives? And I don't know if that's such a good idea. I've seen bad complications from filters too, but especially if it's safe to anticoagulate someone after surgery, prophylactically, then they're getting the best we can offer them. These are 3 studies that came out of our research, 3 publications, about 1 a year over the past 3 years. I did most of the work with a guy named Tim Smith. He's at Brigham now. He's a lot like Andy Bauer, a lot of kids, a lot of degrees, a lot of fellowships. So, but he's also real smart. He's done some great work. So I think it's him. I think of Andy.